I mean, yes, she had COVID. She tested positive for COVID, but that wasn't her reason for admission.
I would think that there's some motivation that it's driving higher rates of reimbursement or quicker reimbursement or something.
The guy went in for multiple gunshot wounds and he was coded as COVID. I'm like, he would have never known he had COVID if he hadn't gotten gunshot wounds. COVID it's interesting. It's the elephant in the room that you're not allowed to talk about. COVID is never going to end if we don't start calling this out.
Tell us your name, your title, where you work.
My name is Jean Stagg. I am a nurse was a nurse with United Healthcare, Community and State Plan of Louisiana. Specifically, I do inpatient utilization management coordination.
And how long have you done that for?
I've worked for United about 7 years. About the last 2 years is when I've done the inpatient utilization specifically.
What brought you here today? Why come to Project Veritas?
Well, I've been seeing some cases come over that were coded as COVID-19 that I felt should not have been coded as COVID-19. I've tried to raise awareness to my leadership and even with the Fraud, Waste, and Abuse Department, and it just kind of fell on deaf ears. And I do have a few patients that, they went in for reasons outside of COVID symptoms, but they are still being counted on our census as a COVID admission. So that may be, showing some higher numbers as well. They did test positive for COVID, but they went in for other reasons, but they are still being counted in our numbers. So any questions?
Yeah, thank you so much, John. That was great.
Well, that's odd. You identified that there were problems, and who are you speaking to there?
Well, this was our daily leadership call. So it's all of our leadership at the Louisiana Health Plan. And every Wednesday, I report off on our COVID inpatient numbers. You can see the trends. Obviously, we're concerned about when we see the spikes and the peaks. And so I try to explain why we're having peaks. It's not necessarily because we have patients that are critically ill with COVID. These are just the patients that are showing up on our daily census as a primary admitting diagnosis of COVID-19.
When did you first notice this trend of coding all new patients as COVID?
Some of them are legitimately COVID-19. But starting in around March of 2020, that's when I started really tracking and specifically focusing on just the COVID-19 patients. And I would say it's around June or July, I started seeing some cases which should not have been COVID, in my opinion.
We have an example here of, I believe, a gunshot patient. Yes. Does that ring a bell?
The one that really got me a while back, and I told Nicole, because I'm like, oh my God, this has nothing to do with COVID. The guy went in for multiple gunshot wounds, and he was coded as COVID. I'm like, he would have never known he had COVID if he hadn't gotten gunshot wounds. I mean, we take the cases as they're sent to us, but I've had a couple where it was like, scheduled vaginal deliveries or car wrecks, different things like that wasn't their reason for going to the hospital. But, like I said, the only way they're going to show up on my census is if COVID is their primary diagnosis. I don't want to say it's fraud and abuse, but I mean, should I be reporting stuff like that or just letting it go?
I mean, the thing about it is we are finding people as we work them up who are COVID positive and they had no inclination to even know they might be positive. But, I mean, when I assess those folks and put in codes, that's never my number one code in that situation.
Who are you speaking to there?
That is Dr. Morial. She's actually my boss. She is the Chief Medical Officer for United Healthcare Louisiana Medicaid. But she also works as a hospitalist at a local hospital. So she's very familiar. She's been on the front line with the whole COVID.
And how would you characterize her reaction?
I think that she was a little bit surprised as well that her peers or the hospitals were doing that. Like she said, she wouldn't have done it in that way.
Dr. Morial, for that $2,100 fee for the one dose of the antibodies. Are people being charged their deductible for that, or is the feds just paying that outright?
The feds are paying for it at this point. But that may not be what's going to happen going forward. The feds are paying for it. But the supplies are somewhat limited.
When Dr. Morial is referring to when the feds are paying for it, who is she talking about?
I would imagine that it has to do with the CARES Act and the federal funds that were allocated through the CARES Act.
Do you believe there's a financial incentive to do this?
I think that there probably is. So I don't see the actual financial side of it, but I have heard rumors, that they are getting money directly from the federal government for COVID positive admissions.
And I'm wondering what the motivation would be for that, because I don't think the reimbursement is going to be any different.
Well, I know that the reimbursement turnover is quicker, right? Because with all of our COVID, it's like a 15-day turnaround for reimbursement, whereas normally we're like a 30-day reimbursement. So,
well, maybe that's driving some of the motivation.
Mm-hmm. And I thought that they got reimbursed at Medicare rate instead of Medicaid rate.
They do.
I mean, Medicare rate would be significantly higher than Medicaid rate.
Yes. Yeah. I would think that there's some motivation that it's driving higher rates of reimbursement or quicker reimbursement or something.
Mm-hmm.
Because otherwise there's no reason to put, something like that as a leading diagnosis in basically asymptomatic patients.
So typically when a patient goes into the hospital, they go through utilization review. So we have a team of nurses that review the patient's stay. We use a standard set of criteria. All hospitals, all insurance companies use the same set of criteria. And we basically are reviewing it and saying the care that this patient is getting meets criteria. They still need to stay in the hospital. If they don't meet the criteria, we deny the stay. Or maybe they shouldn't have been admitted in the first place. We're going to deny that. What happens is LDH, which is the Louisiana Department of Health and Hospitals, they have suspended utilization review. So they're basically telling the insurance companies that they cannot do medical necessity review. We can't deny anything. When that happens, you can see on that chart the spikes in numbers. It kind of correlates when LDH suspends utilization review.
Now, your critics might say that you're just speculating, that you're just assuming, guessing. How will you react to those critics?
I would say LDH is definitely suspending utilization review. It's unprecedented for them to do this.
What are we looking at here?
This is actually a health plan advisory. They have amended it multiple times. And this is basically telling them that all utilization management for all medical hospitalizations, including but not limited to initial service authorizations and concurrent reviews, must be suspended. Now, this is not specific to COVID-19. This is every single hospital admission. We're not allowed to do medical necessity review. So it gives the hospitals free rein to admit anything they want, code it however they want, keep the patients in the hospital as long as they want, and we're not going to deny anything.
Who is giving these directives?
This is coming from LDH, which is the Louisiana Department of Health and Hospitals. And I'll also point out, too, that LDH meets with all of the hospital heads, the CEOs of all of the hospitals. They meet once a week with the governor, and they discuss strategies and how they're going to go forward dealing with this COVID pandemic. COVID it's interesting because it's the elephant in the room that you're not allowed to talk about.
So what's your message to the doctors watching this feeling betrayed by you?
Well, I hope they live up to the oath they took to do no harm. To me, this is dishonest. I don't know that it's illegal because it's being allowed to happen by the CDC. I would hope that they would stand up to their hospital administration, because I'm sure they're getting pressure from their administration to test everyone, test them multiple times, get that COVID diagnosis on the chart. But I would hope that they would stand up. We have to stand up and fight this. COVID is never going to end if we don't start calling this out, what we see.
When I see a patient, and if the patient is presenting with other symptoms,
that aren't suggestive of a COVID infection, even though they may test positive for COVID. That's not my primary diagnosis.